Good afternoon, everyone. My name is Chelsea Lynch from NQF. Thank you for joining us. We will get started in just a minute. Please review the housekeeping reminders in the meantime. All right, Victoria, can you please advance to the next slide? Hello again, everyone. Welcome to the third web meeting for the Leveraging EHR Source Measures to Improve Care Communication and Care Coordination option year. My name is Chelsea Lynch, and I'm a Director in Emerging Initiatives at the National Quality Forum. We truly appreciate that all of you joined us today and that you're prioritizing this work within your busy schedules. Additionally, we'd like to thank CMS for funding this important work. I'm really looking forward to our discussions today as we develop recommendations for how social determinants of health data can be used to improve EHR-based care coordination and care communication and their measurement. I know we're all familiar with these meeting platforms, but always good to share a few housekeeping reminders before we get started. We are on the Zoom platform, which has audio and video capabilities, as well as a breakout group function. Please place yourself on mute when you're not speaking, and we encourage you to keep your video on, especially when you are speaking. Please ensure your name is displayed correctly. If needed, you can edit your name by right-clicking on your picture and selecting Rename. You can also switch your display by right-clicking View in the upper right-hand corner and selecting Speaker or Gallery. As always, please feel free to use the chat box to communicate with NQF staff and with each other, and please use the raise hand feature during discussions to be called upon to speak, and we'll take committee attendance shortly. Next slide. I would like to invite our co-chairs, Dr. Richard Antonelli and Dr. Jerry Lamb, to share any additional welcoming remarks. Rich, could we start with you today?
Yes, hello everyone. I'm very excited to open this meeting with my co-chair and the NQF staff. I hope that you'll have a sense of continuity in the way we're processing this important work from the last meeting into this one. I won't steal any of the thunder of the meeting that's before us, but again, I want you to have a sense of momentum being sustained in this work. My compliments to the NQF staff for the exquisite preparation that went into this, and again to our CMS colleagues for both participation and obviously for the funding to support the work. So welcome, roll up your sleeves, got a lot to do today.
And this is Jerry, and I would echo exactly what Rich just said. Welcome back to meeting 3, and we are certainly maintaining momentum and moving towards some really outstanding recommendations and reports, and I'm really looking forward to the discussion of social determinants today. So Chelsea, back to you.
Thank you, Jerry and Rich. Next slide. So I'll briefly go over our packed agenda. After covering our objectives for today's meeting and taking attendance, we'll provide a recap of our discussion from web meeting 2, followed by an overview of the Gravity project. We'll then move into a working session where we'll break out into 2 groups to discuss how SDOH data can be used in EHRs for care communication and care coordination, as well as quality measurement. After we hear from the report outs from those sessions, we'll have a few minutes for NQF member and public comments, and we'll wrap up with next steps. Next slide. So we'll get started with an overview of our meeting objectives and attendance. Next slide. I'd like to first remind everyone of the project timeline. As a reminder, we have a total of 6 web meetings, and the focus of the first 4 is to develop recommendations. In today's meeting, we'll be focusing on how SDOH data can improve care communication and care coordination and their measurement. So really digging into how SDOH data captured in the EHR could help to facilitate care communication and care coordination, as well as how they are measured. In our March web meeting, we'll be focusing on developing recommendations about how existing and future development of EHR source measures can be leveraged to improve care communication and care coordination and develop some possible measure concepts. Web meetings 5 and 6, we will be reviewing and refining the recommendations and making updates to the 2 final recommendations reports based on committee feedback and public comments. Next slide. So you've certainly heard this a lot already today. So our main objective is to review the SDOH domains within the Gravity project to discuss the impact of SDOH data on EHR-based care communication and care coordination, and begin to develop recommendations for how SDOH data can be used for care communication and care coordination quality measurement. I'm now going to hand it over to Victoria to take attendance. Victoria?
Thank you, Chelsea. I will now go ahead and call attendance. If you are on the line, please go ahead and unmute yourself when I call your name and let me know that you are here. If you're having trouble with your audio, you can go ahead and let us know via chat if you're on the call. I'll start with our co-chairs, starting with Richard Antonelli.
I'm here.
Thank you. Next, Jerry Lamb.
I'm here.
Okay. Kathleen Balistracci. Let us know she will not be on the call. David Burianic. Okay, Brian Buys.
I am here.
Thank you. Sherry Costa. Okay, also let us know she will not be on the call. Cynthia Cullen.
Cindy, please, here.
Okay, hi Cindy, thank you. Keith Horvath.
I'm here.
Thank you. David Key. Okay, thank you. Next, Joseph Kunich.
I'm here.
Thank you. Russell Lefwich.
Here.
Thank you. Michael Lieberman.
Here.
Thank you. Brett Perry.
I'm here.
Thank you. Rebecca Perez.
I'm here.
Thank you. Ann Polich.
Yes, I'm here. Thank you.
Thank you. Walter Rosenberg. Okay. Stacy Schilling. Sue Ellen Shea. She also emailed us to let us know she would not be on. Colleen Scow. Also let us know she would not be on. Alexis Snyder.
I'm here.
Thank you. Maureen Stewart.
Here.
Thank you, Maureen. Jason Weisner. Okay, also let us know he would not be on. Next, Dorothy Whittingham.
I'm here.
Thank you, Dorothy. Kim Yu.
I'm here.
Thank you. Andrew Zinko. Thank you. And I'll go back once more because Walter, I think I saw you join after I'd already called your name.
Yes, hi everyone. Sorry I'm late. I'm also on a laptop without a camera this morning or afternoon. Sorry about that.
No problem. Thank you for letting us know. If I missed anyone else during this roll call, please feel free to unmute yourself and let me know that you're here. Okay, thank you. I will now give our federal liaisons a chance to unmute themselves and let us know that they're on the call. I'll begin with Joel Andrus.
I'm here.
Thank you. Kyle Cobb. Okay. Chris Dimick,
I'm here, thank you.
no problem. Tara McMullen, okay. Carly Madosh, Francine Sandro, okay, and Kenneth Yale. Okay, thank you. Back to you, Chelsea.
Thank you, Victoria, and thank all of you again for joining us. I am very fortunate to be joined by a great team here working on the project. I'd like to thank Udara, who is actually currently out on maternity leave and will be joining us again in a few months. Monica, Victoria, and Jesse for all of their hard work. And I'd also like to introduce Debbie Alawui, a new analyst on the project. And I'd like to acknowledge some additional support from Chet, Carol, Mara, and the IT team at NQF for their help with facilitating and running today's meeting. Next slide. I'd also like to acknowledge and thank Kim Rawlings and DeQuincy Polk from CMS for their support on this project. And next slide. Before we get started, I'll quickly go over some ground rules for our meeting today. As you know, we want to emphasize that there is no rank in this room. Everyone's opinion and insight is valuable. This is a complex topic, so your experiences are critical to the advancement of our work. Please share your experiences and learn from one another. Be respectful to other committee members and create space for different perspectives. Additionally, please refrain from making any political jokes or comments. Next slide. So we'll get started with a brief recap of Web Meeting 2 as a reminder for what we've worked on so far. Next slide. During Web Meeting 2, we provided context on the approach we're taking for interoperability and related EHR attributes, reviewed some background resources for additional context about various concepts related to our project, and reviewed and refined recommendations for how EHRs could better facilitate care communication and care coordination. Next slide. As a reminder, one of the major concepts that is essential for our work is interoperability, which is the ability to share information easily between different systems. To help frame our discussion during the meeting, we shared this slide to depict how we're thinking about interoperability and how it relates to effective EHR-based care communication and care coordination. Interoperable data within the EHR is essential for having an EHR that is optimized for care communication and care coordination functions, which then makes it usable by all stakeholders to have effective care communication and care coordination. However, there's already a lot of work being performed to set data standards and move towards fully interoperable systems, and we don't want to spend time recreating the wheel. We definitely want to consider interoperability when developing all of our recommendations, but we don't want to be constrained by it. In that effort, we are approaching some of our recommendations through the lenses of 3 stages of interoperability: early, intermediate, and advanced. Our hope is that considering 3 stages of interoperability will allow us to develop practical recommendations for our current state, while also not restricting us from making recommendations for an ideal future state. Next slide. In Web Meeting 2, we used 2 breakout groups to discuss recommendations related to how to effectively facilitate care communication and care coordination with EHRs. We reviewed the list of recommendations by theme and did not remove any of the recommendations included in the list. However, we did have a robust discussion about which EHR capabilities and capacities were missing from the recommendations, such as the inclusion of the patient voice across recommendations, as well as the use of shared decision-making when care planning, the importance of timely data sharing, and the ability to track patient care between facilities. Next slide. Based on those discussions, we're in the process of updating the recommendations. On this slide, you can see we added a new theme by separating the optimization of EHR usability for clinicians and patients. An example of a recommendation that might be included under this new theme is having an EHR that allows patients and their caregivers to communicate with their clinicians and non-clinical teams securely, both asynchronously with applications like email and synchronously with the use of telemedicine. Again, we're still in the process of refining all the recommendations based on our discussions, and they will be incorporated into the final recommendations report. Next slide. So before we transition to our working session for today, I'll briefly describe the Gravity project and how it relates to EHR-based care communication and care coordination. We won't be going into a lot of detail, but this should provide a basic understanding of the Gravity project's intent to help inform our discussion. Next slide. So the Gravity project is a HL7 FHIR accelerator project that addresses the needs for both semantic and structural level interoperability of electronic SDOH data. It is a multi-stakeholder public collaborative with the goal to develop, test, and validate standardized SDOH data within the EHR using identified coded data elements. There are several social risk domains identified by the Gravity project, and for each one, they're attempting to create terminology work streams that will create consensus-based represented data sets for screening, diagnosing, goal setting, and intervening. The intent of the Gravity project is not to redefine any of these elements, rather it is identifying existing ways to gather this data and capture it within the EHR so there's a more standard collection of data. All of this is, of course, a large undertaking, so it will take time to fully develop all of these data sets. So the project is tracking their progress, and some domains are further along than others. For example, the food insecurity domain is further along in development and has a comprehensive list of codes already identified. Next slide. As a reminder, Health Level 7 Fast Healthcare Interoperability Resources, or FHIR, is an internet-based approach to transferring and sharing health information to provide seamless interoperability and patient-centered data-driven care. It is a representational state application programming interface that includes specifications for how one system requests and receives data. It includes resources which are discrete data concepts such as patient information, family history, and medication lists, and profiles, which are use cases that tell the relationship and provide meaning to the resources. ONC and CMS both have rules that are requiring implementation of FHIR-based APIs to support the sharing of health information, and this implementation will also help move the field towards digital quality measurement. We're hoping to share a little bit more about the strategies ONC and CMS are using in the March meeting. Next slide. So I also wanted to share a little bit more about how the Gravity project is moving towards implementation. For each domain, multi-stakeholder groups identify common data elements and associated value sets and make recommendations for how to best capture and group these data elements for interoperable electronic exchange and aggregation. The Gravity project then collaborates with coding and terminology suppliers to address any identified coding gaps. For example, in the food insecurity domain, the group identified various screening tools, such as the Hunger Vital Sign tool and the protocol for responding to and assessing patients' assets, risk, and experience, or the Prepare tool, and then worked to develop and map codes that relate to the screening questions and answers. After the codes of the data set are developed, they're tested for use in FHIR and eventually will be part of the HL7 FHIR implementation guide. Next slide. There are 18 Gravity project domains, and I will briefly share them so you can see the extent to which the Gravity project is considering various social determinants of health. So we have food insecurity, transportation insecurity, elder abuse, food deserts, financial insecurity, interpersonal violence, housing instability, material hardship, environment. Next slide. Inadequate housing, homelessness, unemployment, neighborhood safety, veteran status, education, social isolation, racism, and stress. So again, just sharing the breadth of what the Gravity project is working on, and the intent of our discussion is not to judge the data being identified and collected. Rather, we want to explore the impact these data might have on care communication and care coordination and how they're measured. Next slide. So before we transition to the next section, are there any questions or comments or any additional information that could be helpful? Or if anybody of our experts on the panel have anything additional they would like to clarify, by all means, please let us know. Okay, not seeing any. Oh. Okay. So we will go ahead and transition to our working sessions. Next slide. And you can go to the next slide too. And I think one more. So we're using the breakout sessions to allow for more in-depth discussion of the development of recommendations related to how SDOH data can be used to improve EHR-based care communication and care coordination, as well as care communication and care coordination quality measurement. Each person will be assigned to a breakout group with one of the co-chairs and a couple of NQF staff. We'll have about 60 minutes to brainstorm and discuss the Gravity Project's impact on EHR-based care communication and care coordination and considerations for quality measurement. We will then come back together for a report out from the session and discuss any final points as a group. If for some reason you get disconnected or have any technical issues, we have NQF staff available to help provide assistance or to ensure that you get placed back into the correct group. Before we split, I do just want to have a clarifying piece. When we talk about the use of the SDOH data for quality measurement, we might be getting into things like risk stratification and risk adjustment. So a little clarity, stratifying is just you have the information and then you can stratify and review it and compare everybody based on the information. And then risk adjusting is you're actually changing your rates based on the information collected. So don't need to get into a lot of that. We'll have a lot of discussion on measurement in our meeting in March, but just kind of wanted to, again, focusing really on how to use the data for going forward there. So we do on the next slide have our breakout groups. They are the same as last month. Don't need to memorize it. You'll be automatically placed in there. And then our members of the public, we will get you assigned randomly as well. So I think, Jennifer, we can move towards the breakout groups. And then again, we will work on getting everybody else assigned. Welcome back, everyone. I think we're still missing a few people. I think we also might just have lost some to just length of time of the meeting. So I know we had a wonderful discussion in our group. Jerry, I think we mentioned this during the prep call, but we will have Rich take the lead the first report out this time, and then we'll have you join. So I will go ahead and turn it over to Rich.
Thank you, and I want to invite the members of our breakout group to please jump in to add or to emphasize or to modify. I'll start with a simple proclamation of wow. We had really wonderful discussion from the members of our team. We spent just a little bit of time talking about the technology. We really feel that the technology piece, even though it's challenging, I don't want to underestimate it. The bigger challenges are going to be building trust with patients and families, and especially patients and families and caregivers that have a longstanding tradition of not having equitable access, equitable outcomes, et cetera, and whether that is driven by racial, ethnic, linguistic, or disability status. And so we spent quite a bit of time talking about how do you build this idea of trust? Why are we asking for this information? And what are we going to do with it other than satisfying some checkbox? There were several suggestions that came forward of not having that necessarily be by a traditional medical provider, but to develop a diverse workforce that could include patients and families themselves as faculty, home visitors, community-based resources, et cetera. So we spent a fair amount of time talking about developing, cultivating, and sustaining a diverse workforce that could help build trust, not just simply collect the data. One of our family colleagues mentioned that, you know, the locus of where that information is collected, we shouldn't presume that one place, say primary care, is the place that the families would be most comfortable with. One of our colleagues mentioned that they started, that system started their work on the inpatient side, and then they were going to move into the emergency department and ambulatory. So being mindful that what are some of the criteria that would engender trust and a sense of safety and inclusiveness on the front end for the data collection. One thing that I wanted to share, it's a tactic, but I think it's worth it for us to be thinking about. In addition to the training, somebody suggested of, you know, should we go through an informed consent process as we are soliciting this data? The integrated approach to getting information from one member of the team to another in a timely and accurate fashion is really, really important. So the same information is not being asked by every provider across an entire system of care or a community. Building on this notion of the information belongs to the patient and the family and the caregiver, and it follows them through the system of care. A point was raised that just giving somebody a data dump is not going to be most efficient. But once that data is collected, is there a way of flagging certain high priority risk factors so that subsequent providers will be aware of what that would be? So we differentiated flagging from simple data processing as a way of tracking information utilization through the patient's journey. ARC has funded some studies now. We don't have the data, we don't have the outcomes yet, but looking at predictive modeling based on some of these risk factors, and is there a way of prospectively identifying patients that will need services? And then importantly, when a profile of a patient is flagged, how do you once again build on trust? Rather than giving the family a sense that this is a deficit-based approach, you have so many risk factors, and that actually undermines patient-centeredness and the sense that they're really able to prioritize their care needs. So how do we maintain that notion of trust and give the patients and families as much agency as they can in this process? Sensitivity training for the folks that'll be interacting with the patients in any of these settings, irrespective of where that would be, so that we're sharing information, especially information that would on its face suggest vulnerability, and so that there would be active training of the workforce in this space. We talked a little bit about some performance measures. There aren't a whole lot of existing performance measures in the space of care, communication, care coordination related to SDOH. So we did some high-level discussion of measure concepts, frequency of screening, accuracy of the data and the provenance and the utilization of those tools, and a ill-defined measure concept, but I think for me it's something that's really important, is a measure of, is that data being used in other encounters that wasn't the index encounter at which that data was collected? So in other words, some continuity over time and setting of data utilization. And then finally, what's missing? Sexual identity and orientation and disability status are missing from the Gravity project, and access to care as well. I would like to open it up to Chelsea and other members of the team. If I missed anything, please jump in.
I think you did a really nice job, Rich. I think the other piece is just, and apologies if you said this while I was doing some other things on the back end for the meeting, but making sure that the data collection processes match the workflow, and just being really cognizant of the collection burden, especially, there's 18 domains for Gravity projects, and so that's minimally 18 questions. And so really, thinking through how that gets implemented. And then also this idea of once we have this data, really using it and kind of identifying, potentially what are the 1 or 2 questions that are actually really impacting the outcomes, and really helping to narrow it down, which I think will be helpful once we actually have the data that we can start working with.
Rich, one thing that struck me as you were just recapping our discussion on trust, we are very focused on the data that are sort of in question for the Gravity project, which tend to be more sensitive, and we need trust to be able to share them. I think if you step back for a moment, the care with which we handle broader demographic data, your name, your address, who you are in other ways, actually can also engender trust. I had to take my son to the urgent care last night, and we were asked 3 times to enter his name, and then they got it wrong later. And I think sometimes the manner with which we handle data that maybe aren't as sensitive but are very still personal actually can engender some trust. And so it just struck me as you were saying that that while our focus is here on SDOH, some of the things that don't seem as pertinent, I mean, they are your name and your identifiers and the system and things, but the way we handle that can also engender trust or not. So it's just a thought.
I could not agree with you more, Brian. And that's why I kept referring to trust with lots of legacy issues, right? If we get your son's name wrong, how can you possibly begin to trust us with even more sensitive information that you might say, what does this have to do with his urgent care visit tonight? The fact that we are housing insecure, et cetera. So I'm bringing that forward, by the way, not to spread disillusionment, but in fact to energize all of us to recognize that the healthcare system, broadly defined, has some making up to do. And especially closing those gaps in credibility and trust. So yeah, thank you for that. Anybody else from our team before I hand it over to my co-chair? Maureen Stewart, your hand is up.
Hi, everybody. Can you hear me?
Yes.
I just really quickly, anecdotally, as a caregiver and a patient myself, I just wanted to say that is so true. There's nothing that sparks distrust or mistrust more than calling to make an appointment, and whoever answers the phone or presenting to a clinician saying, what's the name? What's the name of or what's the date of birth, rather than referring to people by their name, or what's your child's name, or what is your name, what's the name. It's a really simple place to start, but that is kind of the kickoff of what, as a patient or a healthcare consumer, I mean, just from that starting point forward makes you think, well, this is kind of a cattle call medical establishment or urgent care or hospital or whatever. So the way you approach people initially really makes a huge impact on how they perceive your level of interest in their well-being going forward.
Maureen, thank you so much for that. In fact, in our group, we talked about not just asking families to react to what we would be developing in the trust engagement front end, but in fact, having them be key informants and even faculty in some of the training. So there is absolutely a place for proffering experiences like that, and hopefully including it in some of that sensitivity training. All right, anybody else from our breakout group? And if not, I will hand it to Dr. Lamb. Okay, Jerry, to you.
Thanks, Rich. We had a very rich discussion too. And so going to start with, so what impact would gravity have on care coordination and communication? And like the other group, we thought this was very important also, that it could have unintended consequences without dealing with the sensitivity and trust issues. We noted that while SDOH is not conceptually new, what is really critical is the standardization, and felt that the standardization of these elements would contribute to consistency about how we communicate SDOH, as well as seamless connections across the care continuum, reducing redundancy so that, as Brian was talking about, you don't get asked the same thing 22 times. Also important for tracking and benchmarking to outcomes, which is just absolutely critical in both processes, and being able to track these elements across providers so that regardless of team changes, this information was available. In terms of other things that it would allow us to do that either we're not doing now or could do it better is tracking referrals. Gravity does include standardized definitions for the types of services and categories of services. It would allow better linkages to community-based organizations and also be able to identify which ones were doing an amazing job. And that it would be better decision-making about how to address issues in social determinants of health. We also, and Joel helped us with this, addressed what are the implications of this for certification standards in EHR, and wanted to hear more about that at the next meeting. In terms of data considerations, we also went into the topic of trust and sensitivity, who's going to have access. We did talk about what provenance means, and I think that needs to be defined more. That in FHIR, it's not only where does the data come from, but who put the data in, who said it. And we also felt that looking at who puts that information in terms of accuracy, sensitivity, and privacy was important. We wanted to see protections against using these data in ways that would increase disparities and bias. In terms of operational stuff, the recommendation is let's put the data in the same place so everybody knows where it is, and deal with issues related to who has access to the data. There was also the call for dealing with cost considerations, that recognizing there's a lot of SDOH, it's time consuming, there are language issues, and that small organizations may not be able to afford collecting it in an ongoing way. We did fast forward to the future about use of other technologies to assist with data collection, including AI, and began but did not get into depth about that whole idea of the human tech interface of care coordination and communication being very human interaction, and how do we do it so that we don't move into a checklist mentality. How SDOH could be used, we too got into a whole, the beginning part of a discussion of risk. Jesse helped us with risk stratification, risk assessment, risk adjustment, and we also began to look at how is that tied to coding, so that there is consistency in how we're using SDOH and how payment structures refer to it. We also need to look at data aggregation at the population level. And lastly, when we raise, so what else is out there besides Gravity Project that we could be looking at for care coordination and care communication for measurement? We were not able to come up with anything, but we did encourage each other to think about that. All right, group one, what did I miss? What did I get wrong? What do you want to add? Not seeing any hands. Okay, so
Jerry,
I think we got,
this is
go ahead, Chuck.
And I apologize, much like Chelsea, I'm doing some work on the back end as well, so I apologize if you said this, but there was one comment that really resonated with me as well, that using these data provide an opportunity to understand the source of why a patient becomes non-compliant and really dig into that, to dig into the root causes, the transportation issues or whatever may be, rather than the system as it exists now, where that patient just kind of gets written off as non-compliant. So that was the only other thing. I may have missed if you said it, but that was the only other thing that stood out to me.
No, Chuck, that was really good. We did comment that one of the cool things about Gravity is the fact that it deals with concepts and measures related to screening, diagnosis, goal setting, and intervention, as well as evaluation. And that is just so core to care coordination and care communication. So the way that it's set up, you know, I think there were comments that it really aligned nicely with care coordination and communication processes. And Chelsea, I am so glad we are recording this because there were so many comments and everybody had such great things to add. And I'm sure, you know, we have missed a lot, but I think there were some really critical things that aligned between groups as well.
Yeah, I agree. Also, it's vital for us to record these. I completely agree. Our note taking is only so good. But it looks like we might be able to go ahead to the next section, Victoria, if you're ready.
Okay, I will now open it up for NQF member and public comment. If you would like to make a comment, please feel free to raise your hand using the reactions feature at the bottom. Or if you are on the phone, please go ahead and unmute yourself if you would like to make a comment. Give it another few seconds, but please feel free to raise your hand if you have a comment or go ahead and unmute yourself. I don't see any hands raised and no one unmuted. So I will go ahead and go on to next steps. Okay, next steps. As a reminder, you can submit any additional input on the SDOH domains and ideal capabilities and capacities of EHRs. That's from this meeting or previous meetings as well, to our email, the project inbox, which is right down here. Our next web meeting will be held on Monday, March 21st from 12 to 2 p.m. Eastern. Please note the time change. Our last two meetings were 2 to 4. This one will be from 12 to 2 p.m. And please contact the project team with any questions, or if you do not receive any of the meeting invitations or materials prior to the meeting. And I'll turn it over to Chelsea.
Thank you, Victoria. And thank all of you again for joining us. It was truly an incredible conversation per usual. It's nice to be able to split into the smaller groups so we can, have more discussion, but then also feels a little bit like left out when you're not a part of those groups. So as Victoria said, our next meeting isn't until a little bit later in March. So before those meetings, we will share web meeting 2 and web meeting 3. I almost forgot what meeting we were in. Both of those summaries to get you up to speed before our March meeting. And then, we are looking forward to seeing all of you then, and I'll go ahead and hand it over to Rich and Jerry for any final remarks.
I'm still trying to catch my breath. We covered so much ground, and as somebody who's had the privilege of working and supporting the mission of NQF for many, many, many years, I have to say that I am uplifted and excited. We covered a lot of non-traditional discussions today. We're in the functional space, and I think that is so right-minded. We probably use the word trust today more than we did outcome measure, and that's really important to everybody. I hope that you share this perception of a sort of a change in the approach to do meaningful work, to eliminate disparities driven by race, ethnicity, language, and disability status, and to meaningfully and trustingly address social determinant of health and health-related social needs. It's going to take this level of discussion. So thank you, everybody. Please stay hungry for the work ahead. We've got a lot more to do. I think in March, we're going to be jumping deeply into measurement, so stay tuned. So thank you, and Jerry, I'll hand it to you now.
You read my mind, Rich. I think we all came to this work with such a deep commitment to the work of care coordination and care communication measurement. And I hope that everybody on the committee and the NQF team and all the folks that are supporting us at CMS and ONC and the other organizations are feeling what Rich just said, which is the depth and the meaning that we all brought to this, and the fact that we're dealing with the human as well as the technological. We're all learning about interoperability and FHIR, and it's all coming together. I think the next meeting 4, is going to be absolutely essential in pulling this together in terms of where we need to go in measurement in EHR. So I just encourage you, please put it on your calendar, please be there, continue to just join in this conversation with your recommendations. I'm just so thrilled with all the voices that we have from the community, from the professional organizations, from clinicians, from all the members of the healthcare team. So thank you, and I look forward to seeing you on March 21st. Remember that daylight savings time happens before that. And so those of you like me who are on the West Coast, our time will be even more different than it is now. So please keep that in mind. See you in March.
Thank you, everyone. Have a great day.